Hello everybody, thank you for joining me. I'm Lorraine Creech, Head of Nursing at Mesothelioma UK, and today we're continuing with our interviews of very special people, and everybody we've had so far has been a very special person, but for me it's been really interesting, and I hope you're finding all of our interviews interesting as our mesothelioma community comes together. Today I have the great pleasure of interviewing Sanjay Popat, Professor Sanjay Popat, who is Consultant Thoracic Medical Oncologist at the Royal Marsden Hospital in London. And I have to say now I'm going to have to read a paragraph, which I don't normally do, but it just outlines everything that he has input into as part of his role, which is absolutely amazing. So he is the co-director of NIHR London, that's the South Clinical Research Network Cancer Division, and he's the chair of Cancer for West London Genomic Medicine Centre. He chairs, as we know and all love him for, the British Thoracic Oncology Group, which is BTOG, and the UK NCRI Lung Cancer Clinical Studies Group, Advanced Disease Group. He's active in European Organisation for Research and Treatment of Cancer, that's the EORTC, which I'm thankful that BTOG gives us regular updates of every time we come together on a BTOG event. And he is also a member of the International Thymic Malignancy Interest Group, which is ITMIG. Is that fair to say, Sanjay, or?
Yeah.
Have I cut anything short there?
No, that's a pretty accurate summary of where we are.
It was quite a lot to get my tongue around, let me tell you. So anyway, thank you. After saying all of those fingers that you got in all those pies now, can you just tell us a little bit about your career pathway to date?
Yeah, I think, I mean, some of it has been pretty standard and some of it has been a bit unusual. And at the end of the day, I think I've sort of ended up where I am at more out of serendipity than anything else. I mean, I qualified as a doctor in 1994 from Guy's and St Thomas's Hospital Medical School. I did quite well as an undergraduate. I had spent an extra year as an undergraduate doing what's called a BSc, which basically allows us to spend an extra year deep diving into a particular area of interest. And I spent a year doing a BSc in experimental pathology, which basically meant at the end of the year, I had a pretty solid grounding in human immunology. We did a little research project on something called NK cells, or natural killer cells, which are a type of immune cell. Gave me a really solid grounding in molecular biology and genetics. And then I qualified as a doctor. I wasn't really sure what I wanted to do. I was fairly sure what I didn't want to do, and I didn't want to be a surgeon. And then I spent the next 4 years doing a variety of junior medicine jobs in and around London at some pretty impressive units I was lucky enough to work for. So I worked at the Royal Brompton Hospital for quite some time, doing ICU, cardiology, Royal respiratory medicine, as well as the Royal Postgraduate Medical School Hospital at the Hammersmith Hospital at that point, doing haematology and gastro. And at the end of that, I had got all my sort of qualifications to train to be a physician, to decide on a specialty. And then I came to the Marsden to do solid tumor oncology, having a pretty solid grounding in hemato-oncology and acute medicine. And met a very influential chap in my life there called Martin Gore. He's a recently deceased medical oncologist who influenced me in many ways, actually. And it was the first time I'd ever been really exposed to cancer or oncology. And I just loved it for many reasons we can explore perhaps later. And then I decided, oncology is what I want to do. So I went off to do a PhD in genetics. for 3 years, finished that, and then started my oncology training, which took a bit longer than usual because I integrated that with a postdoctoral research program as well. And then in 2007, I was appointed consultant here at the Marsden on the lung unit, and have been working here thereafter to be appointed professor here with the Institute of Cancer Research a couple of years ago.
What an amazing career pathway. And I think you highlight how doctors, nurses, healthcare professionals often become a product, don't they, of the people we've brushed shoulders with, those people who have influenced us and in some ways made us what we are. So research obviously is a major part of your practice, very close to your heart. What would you say your major research involvement and interests are at the moment?
Yeah, I mean, I think in oncology, you really have to be a researcher to really advance the field, because there's no way of doing it in any other way. And I'm privileged enough to work in a position where I can affect that and make that happen. And I just love it, Lorraine. It's a really close passion for me. I just want to make sure that we can continue to advance the field. And there are two areas which I really enjoy. One area is developing new drugs. So the process of taking something which is otherwise a chemical and turning that into a drug, and developing that and working out who's the right group of patients to use it in, what's the right schedule, proving that it works. And that's usually a series of different trials that you have to do over a 10-year program, perhaps, with some drugs. Some drugs make it, some drugs don't make it. But that for me is really interesting. And what is really critical is engaging with industry, because they often have a lot of interesting chemicals, but they may not necessarily know what to do with that chemical. Is it really going to fly? Is it going to be a drug? What type of patient should it be tested in? How should it be tested? So that is a really important passion for me. And the other thing is with my interest in genetics and genomics, as genetics is becoming far more mainstream now, is really understanding more about the cancer genome and implementing that to not make cancer genetics something for the hoi polloi and the great ivory centers, but something that every single oncologist is used to using, every single nurse specialist is comfortable with the language, and really trying to implement that within routine clinical care to understand what it brings to our patients' treatments. And I like to think in my own little way I've achieved a little bit of that over the course of the last few years.
Yeah, I think we have interviewed some of your patients in the past, and they have mentioned just exactly what you're saying about, finding the right patient for the right drug for the right patient at the right time, and that precision medicine. And I think it's amazing how people like yourself can, take something from bench to bedside, really. So, and always keeping in mind it's the bedside or the home bedside that we've got to get it to, or the consulting room. But it's a amazing path, isn't it?
But it's a team effort. It takes a village. It's not just a one-man affair. There's whole rafts of teams involved in this whole process. You have the people that develop the drug. You've got the research teams, the research nurses, the research practitioners. They're the people on the ground that really deliver the drugs. There's the whole clinical trials unit infrastructure, the folk that run the experiment that's called a clinical trial to make it scientifically valid. And in some trials, we're having to do the genomics as well. So there's a whole infrastructure in the lab about doing the tumor, sometimes blood molecular analysis, and then interpreting the findings. What does it mean? Does it really mean anything? So actually, it's a massive infrastructure that you've got to have to be able to deliver all of this. You can't just suddenly do it on your own. You have to have the infrastructure to be able to do this well.
Mhm. I think it brings to my mind as well about the multidisciplinary team meetings and how they've changed from, as we turned into the 2000s, and, people were saying that the multidisciplinary team meeting was helpful, but perhaps it was qualitative, perhaps it was how we improved people's care by talking about them. But now we've come 20 years later to having the correct discussions about really cutting edge topics can change patient care.
Yeah, there's no doubt about that. I mean, I think, now we have centralized MDTs for patients with mesothelioma, and that's really important because, at the end of the day, mesothelioma is still a relatively rare diagnosis. I mean, commoner in some parts of the country than other parts of the country. But it's really important that every patient is discussing a specialist MDT to make sure that we're not missing an option for a patient. There may be some treatments which are available in a trial, which we may not have, but somebody in another center may have open. And it's really, important that we make sure that we discuss all of these treatment options and make sure that we've really nailed the type of disease that the patients have. I mean, Lorraine, you and I, can remember when mesothelioma was an untreatable disease.
Exactly.
When I started, I mean, I think the first patient I ever saw as a young, we used to call them pre-registration house officers in those days, back in '94. One of my jobs was to tell a patient who had a diagnosis of mesothelioma that his diagnosis was mesothelioma and that there was no treatment. And that was back in '94, and actually things didn't really change for a long period of time thereafter. And I remember coming to the Marsden in '97 and treating patients with cancer. And at that time, we were starting to treat some patients with meso with chemo. And then when I went back to working as a young junior oncologist with Mary O'Brien, this is sort of back in 2001, we were starting to, we were using mesothelioma chemotherapy as routine in our center. It was pretty standard for what we were doing. And I was just amazed at how many discussions I would have with other oncologists around the UK or chest physicians where there was this just nihilism. There is no treatment for mesothelioma. Why are you bothering? It's really not going to make any choice. But I think what I've learned over that period of time is only through understanding the science, sharing the data, doing good clinical research, can we really form a body of work that demonstrates that we can improve outcomes for patients with mesothelioma. We can do it highly effectively, and as new treatments come online, we can integrate those within our standard of care treatment standards quite effectively to really push the field forward. And so if I look at where we are now to compare to where we were in 2001 or even '94, I mean, it's completely different, and I think that's only a good thing. It's great that we've got this far.
I mean, in the 90s, I was a Macmillan palliative care nurse, and again, like you, people were being diagnosed with mesothelioma, and really, what was mesothelioma? There was no treatment for it, straight onto palliative care and presenting very late. And I also wonder how many people we missed. We didn't even give them a diagnostic label of mesothelioma because we thought it was lung cancer or another form of abdominal cancer, which can still happen, unfortunately. So, So what do you think the treatment for mesothelioma looks like in the near future?
Well, I think it's going to change quite a lot. I mean, if you imagine how it's changed over the past 10 years, I mean, it's changed at a massive pace. We've started using old-fashioned chemotherapy. We're now starting to use modern chemotherapy. We've started to use immunotherapy. We are figuring out how to integrate surgery within the treatments. We've got pretty advanced radiation techniques coming online. They're going to start to be integrated, and we've got a deeper understanding of the biology as to how asbestos causes mesothelioma. We don't really understand that greatly, but that's starting to be better understood. We understand now there are different types of mesothelioma. There are, different subtypes of mesothelioma. We're starting to understand that the genes that you're born with may impact on developing mesothelioma. So all of these things are really going to be critical to how we move the field forward in the next 10 years. But I think if you think about what we've learned and you combine that with advances in radiation, advances in surgery, advances in new drugs. I mean, only a few years ago, immunotherapy didn't exist. It's only really come online in the past 5 or so years in the other tumor types. So, what new class of drugs are we going to identify and develop over the next 10 years? I think there's going to be mind-boggling amount of change. And I think if we have this further discussion in a further 10 years, which I really hope we do, I'm sure we'll say actually things have changed markedly again. I think we're going to get to the stage where we're going to be routinely gene sequencing tumors. We're going to be routinely using immunotherapy. I think there'll still be a role for chemotherapy. We'll have new drugs coming online. We'll better understand an individual's specific genetic issues in their tumor and be able to drug them far more effectively than we can now. So our concept of personalized medicine for meso, I think, really will kick off in the course of the next 10 years.
Do you think we'll be able to look at it as a chronic disease rather than the end stage disease that we're looking at?
Yeah, I hope that we can. I mean, there are some patients who we are starting to, use those terms. They've done very well with a variety of sequential treatments, and some patients have done incredibly well with immunotherapy, although they are by significance, the minority of patients do have long-term benefit with immunotherapy. But we are seeing this, and I think we will start to be able to think about mesothelioma as not the terminal disease that the diagnosis is, but about how we can live alongside it and monitor it and change our treatments accordingly. Now, I think that's some way off, but I don't think that it's an impossible concept, because we've done that in other types of cancers. I mean, lung cancer was a untreatable disease back in 2001 and certainly in 1994, in the same way as mesothelioma has been. We've just understood more about the biology, and we've understood that at the same time we've had developments in medicinal chemistry. So if we have developments in the biology of mesothelioma in parallel with developments in medicinal chemistry and new drugs coming online, there's no reason why we should be in a difficult position again. So I always like to think the glass is half full, and there is every reason to be optimistic.
And we've largely dispelled the nihilism that we both say that we encountered over.
Yeah, I mean, I like to think we have, and I think the specialists have, because we see these in our patients where we can really make appreciable differences. But Lorraine, I don't want to be too optimistic and think mission accomplished, because actually it isn't. We're a long way away from eradication of nihilism in mesothelioma and other cancers, and we as experts and leaders have a lot of work to do to ensure that mesothelioma has its place at the table, that people know what the disease is, they understand that it's a preventable disease. That's the first issue. And the second issue, they understand that there are treatments for it. There are many folk still who haven't really grasped that this is a treatable disease, and I think that's something that we still need to hammer that message home day in, day out.
Mm-hmm. Well, moving on, I mentioned earlier that you are the chair of the British Thoracic Oncology Group. To me, that's a family. It's been a great source of information and expertise to be included in and to share with. What does it mean for you?
Yeah, I think you used the right word, Lorraine. It's a family, and that's what I've found myself the centre of, really, this sort of national and sometimes international family, group of healthcare professionals and patient advocates that work cohesively to improve the outcome of our patients with thoracic malignancies. I mean, that's the mission of what BTOG does. It's underpinned by 3 fundamental principles: one of education, one of research facilitation, and one of advocacy. And we do that in many different ways. I think what we're best known for is our education, because the world of thoracic malignancies is changing very, very quickly, and experts are coming online all the time. People are retiring, changing jobs. We've got new nurses coming online. Nurses are getting more and more empowered and are actually doing a lot more of the direct day-to-day care and decision making now than they ever were before. And I think that's only a good thing. That's a great thing for our patients, that we can have that tight relationship. So I think there's a big need for what BTOG does. And what I found is actually we're all in it together. And we're all working for this, we're all working together for the same cause, and it's great to find that we're part of one family. And when I look at other countries, there isn't that same level of national cohesion across a particular specialty, at least that I've come across, obviously. So it's great to have this sort of UK family where we're all trying to work for the same thing.
I can see we're coming to the end of our meeting time here, so thank you for joining me. But just tell us briefly, how do you unwind?
That's a good question, actually. I'm not sure I do. I'm a bit of a workaholic. I said to my wife yesterday, "How do I unwind?" She says, "Well, you're on Twitter all the time, so I guess it must be Twitter." So yeah, no, I like Twitter. It keeps me up to date. It takes my mind off things, but I also like watching cricket. I'm a great armchair cricket fan, so whenever cricket's on, I've always got a beady eye out for that.
Professor Sanjay Popat, thank you so much for joining me today.
Great.
Bye bye. Hope to speak
All the best.
to you soon.
Bye bye.